So Barry, the experience on the elderlies with the pulmonic valve replacement, would you expand a little bit on that, specifically indications and clinical results?
Sure. So most of those patients were Ross patients that we did who are older. We've had really very gratifying experience in those patients. Most of the patients that we deal with who are younger are asymptomatic, and we're doing that to prevent deterioration and long-term problems. When you get to the older patients that we're doing with Ross patients, they've typically often been lost to follow-up, and they present symptomatically. They've typically got right-sided failure symptoms, and it's been very gratifying that we find that they've got severe conduit obstruction. We're able to deal with it and place a valve, and symptomatically the patients get much better. So we've actually had really quite good experience with those patients. I'd point out that what's interesting is from a vascular access standpoint, for most of these patients, we have just been putting a single figure of 8 stitch just at the skin when we come out with these devices and have not had difficulties with it. I had one older patient where they had very lax tissues. We put a stitch there and they've developed a large hematoma. But other than that, we have not needed to do stitching and other things for the vascular access issues. But I do worry a little bit in the older patients that we need to be a little bit cautious about that because their subcutaneous tissues are pretty lax.
Well, that's wonderful. We have the honor to have Dr. Michael Ritter here too, if he is so kind to join us for our fellow competition. And we are just waiting for our first fellow to transmit directly from Sinai. Yeah, Dr. Abisaid is asking me about the live case, and the answer is at this particular moment we are postponed for the live case, so we're not going to have a live relay at this moment.
Pedro, can I maybe ask you about some of your experience with starting a new site? So obviously you'd been involved with the TAVR program at Sinai when we first started. You guys had first started, but then moving this off-site to be able to expand that therapy to different populations. What sort of challenges did you have, or what sort of thought process did you have in terms of being able to set it up? Because I know you've had really excellent outcomes. What's been your secret sauce?
Well, thank you, Barry. That's a very nice question. And yes, our program started last year. We're going to complete 100 cases very soon. And really, it's been a team approach. The most important component at the beginning for everybody in the audience that is interested in this is the support of the hospital. The hospital has to provide the hybrid room, which in many hospitals may just be a room that can be adapted. It also involves the air, the negative air pressures, all these things. But if you have the hybrid room, then you need the people. And certainly our main driver to success has been our TAVR coordinator, which our NP TAVR coordinator is Chandra Beam, who's here. She has single-handled the most hurdle and the most difficult component, which is coordinating all the testing for these patients that are usually elderly and handicapped, to do it in just one visit, and including all the CTs and the surgical consults, and then have at the site expertise so it goes flawless. And I owe that also to my friend and colleague, Dr. Jason Kovacic, who is not here today, but brought us expertise right off the bat, allowing us to have excellent results. Actually, today I got the evaluation from our independent hospital association, who actually noticed how the results has been extraordinary. So go ahead and do it. Don't feel afraid. Be very, very meticulous on the protocols. Most importantly, the evaluation as a heart team approach. And then the in-hospital follow-up, as well as the 30-day follow-up with the activity registry, is fundamental. I guess if anybody's in the audience interested in this, I'll be more than happy to expand, but also to take any questions. Also, Dr. Abisaid here, can you expand on this?
Yeah, no, this is an important issue and working very hard also in Brazil to organize all these centers. But let me switch gears a little bit since we heard the presentation from Eberhard Gruby on mitral, different devices for mitral insufficiency. I think that's it's going to be our biggest challenge in the next few years. So, Michael, from the surgical perspective, I was particularly interested in one of the devices that Eberhard showed with this semi-moon, let's say, that will only essentially replace the posterior leaflet. Is this something that can really work? I was intrigued when he showed me that device.
Well, I think it's a fascinating concept because I think what a lot of people forget is that the anterior mitral leaflet acts as a shuttle valve that funnels blood into the left ventricle and starts it in a counterclockwise vortex. This helps with the left ventricular filling. It decreases energy loss as the blood comes in and has to make a 180-degree turn to go back out the valve. So anytime I replace your valve with any kind of total valve replacement, that totally goes away, the blood comes in and hits the septum and immediately becomes chaotic flow, which means there's going to be a big energy loss. So anytime you lose your anterior leaflet, you change the physiology of flow through the ventricle. So that's an interesting concept. The Alta valve is an interesting concept. And then, of course, as you know, we've done the first-in-man transvenous transeptal neopapillary muscle and cords for degenerative MR. So a total chordal repair done transcatheter. That was Steve Bowling presented that at TCT, and it's going to come out in JACC Intervention. We got our next couple of patients lined up after the first of the year. I hope by the middle of next year we'll be running an early feasibility trial on that. So, that maintains, just like we know when we do mitral repair for degenerative MR, if you're asymptomatic when we do you return to a normal population survival curve. And I'm just sad that I'm not going to live another 20 years because I think that's going to be commonplace. I really do.
Who said that?